For cardiovascular examination, like every other examination, we must always greet our patients. Greet, create rapport, introduce, and ask for permission. Okay. Okay. And for cardiovascular examination, you must position your patient. Okay. Not only that the patient must be in anatomical position, the patient must also be in cardiac position. Okay. So you must be seen to be adjusting the bed to a cardiac position. Even if you cannot adjust, you must tell your examiner that you wish to adjust the head of the bed to a cardiac position, and he might say go ahead. All right. So always adjust the head of the bed to a cardiac position for cardiovascular examination. So we begin cardiovascular examination. The cardiovascular examination slightly differs from other examinations in that we go from vascular to cardiac. Okay. So the first thing we do cardiovascular examination is the pulse. We examine the pulse. Okay. In checking the pulse, we want to know the rate, the rhythm, and the synchronicity. All right. So for the rate, we place our hands, the palmar part of our fingers, over the radial pulse, and we time for 15 seconds and multiply by 4. While palpating, we also want to know the rhythm of the pulse. Okay. And we also try to get the synchronicity. So while getting the synchronicity, while examining, we also place our other hand over the radial pulse of the other limb. I want to check the synchronicity, so just check it for 3 seconds. Know if they are synchronous, if they beat together, or if there's a delay, the radial delay. Also, we also check for the femoral pulse, right? Check if there's a radiofemoral synchrony or there's a radiofemoral delay, right? Asynchrony, all right? So after that, we move on. We slightly adduct the upper limb to examine for locomotor brachialis on the medial aspects of the elbow. All right. Next up, we quickly want to check the blood pressure of the patient. Now you use a cuff, an appropriate size cuff. Okay. And the first thing we do, we inflate the cuff while palpating the radial pulse. Okay, so this is the palpatory method for blood pressure measurement. Okay, so we inflate the cuff while we palpate the radial pulse. Okay. So once we stop feeling the pulse, we inflate further 20 millimeters of mercury higher. Okay. Then we place our stethoscope and place it in the cubital fossa. Okay. And we must be seen to be deflating slowly. All right. Okay, so that's that. So after that, we remove the cuff. This is an aneroid sphygmomanometer, but in your examinations, you may be given a mercury sphygmomanometer, so you must know how to use it. All right. So for the purpose of this demonstration, we're using an aneroid sphygmomanometer. All right. So next up, we want to look at the jugular venous pulsation. All right. So ask the patient to look right, to look the other way. Okay. So Mr. Desmond, please, can you look the other way? Turn your neck and face the other way. Thank you. I'll look at the neck. Most of your patients you're going to get are not going to have prominent jugular venous pulsation. So if there's no jugular venous pulsation, you just move on to other examination. If there is, however, if you see a visible pulsation, you want to confirm that it is a jugular venous pulsation. And if it is, you must measure. So to confirm, you can just do a simple abdominal jugular reflex. Okay. So if we palpate the abdomen over the right hypochondrial area, and the jugular venous pulsation becomes more prominent, then it is actually the jugular vein that is pulsating and not the carotid. Okay, so we want to know what exactly the pulsation is. If it is not prominent, then we'll ask the patient to turn and continue the examination. So Mr. Desmond, can you just turn? Thank you. All right. So next up, we inspect the precordium. The precordium is the chest, the area of the chest just overlying the heart. Okay. So we look at the precordium. Is the precordium normal? Is it normoactive? Is it quiet? Is it hyperactive? Okay. So if we say the precordial activity, we'll just look at the precordium. Okay. So after inspecting the precordium, next is we'll palpate. All right. So the first palpation we'll do, we'll place the examining hand over the left hemothorax. Okay. Just the parasternal area. All right. So when we place, we want to feel if there are murmurs at the area, the corresponding areas. Okay. So we'll start with this. Okay. If we don't feel any murmurs, we'll move like this. If we don't feel any murmurs, we'll get to this point. All right. So when we place our hands this way, we'll now try to identify where we can feel the apex beats. All right. So if we can identify it with a finger, tip of your finger, would count what rib it is. Okay. So the second rib is attached to the manubrosternal junction. So when we identify the manubrosternal junction, sternal angle of Lewis, would the second rib is attached to it. So the intercostal space just below is the second intercostal space. Then we'll move second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space. All right. So once we get where it is, the fifth intercostal space, or wherever the apex beat is, we'll try and draw an imaginary line to connect the clavicle. Okay. So we want to know if it's middle clavicular line, if it is 2 centimeters lateral to the middle clavicular line. Okay. If it's on the anterior axillary line, middle axillary line, or posterior axillary line. Okay. So we want to identify, we want to locate the apex beats. All right. So that's for palpation. Now, do we percuss the chest in cardiovascular examination? No, it is not conventionally done. All right. So we'll move on to auscultation. So in auscultation, we also remember to listen over the areas of the corresponding valves, A, P, T, M, aortic, pulmonary, tricuspid, and mitral. The aortic area is the second intercostal space right to the sternum. Okay, second intercostal space, right sternal border. So second intercostal space, left sternal border, we have the pulmonary. Okay, fourth intercostal space, left sternal border, we have the tricuspid, and we have the mitral around the fifth intercostal space or fourth intercostal space, mid clavicular line. Okay, so we'll listen at those areas to pick up murmurs. Okay, the heart sound. We want to get the heart sound. Okay, so we want to know what heart sounds we hear. Do we hear S1 and S2? Do we get any murmur? We must always identify that. And if we get a murmur, where is it loudest? Is it loudest at the aortic area, the pulmonary area, tricuspid area, or at the mitral area? Okay, so that's what we do in auscultating for the chest in cardiovascular examination. Next up, furthermore, we want to examine the chest, the abdomen, and check for pedal edema. Those will help us to identify other symptoms of heart failure. Okay, so we want to examine for the chest. In examining the chest, we just want to listen to the breath sounds at the 3 lung zones. Okay, so breathe in, out, 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 breathe in, out. Okay, so we've listened to the chest, we've auscultated the chest. So after examining the chest from the front, we ask the patient to lean up so that we can listen from behind. Okay, so Mr. Desmond, please, can you lean up? Thank you. So breathe in, out. 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 Okay, so can you leave that? Thank you very much. So next up, we want to examine the abdomen. Okay, in patients with with cardiac failure, they could have hepatomegaly, maybe tender. They could also have ascites. So we just target our abdominal examination to examine for the liver and to check for ascites. Okay, so we try and examine. Okay, breathe in, out. Okay, in, out. Okay, in, out. Okay, so if there's no hepatomegaly, there's no liver enlargement, then there's no need to go further. Okay, then we also want to check for ascites. All right, so we can just do a simple shifting dullness. Okay, so ask the patient. Okay, so if there's no evidence of ascitic, there's no evidence of ascites, then we'll go ahead. If there is, we want to further characterize the ascites. All right, so after that, we just go to the foot of the bed and check for pedal edema. You must always be seen to be looking at the patient's face for tenderness. You must do no harm to your patient while examining. So, in examining your patient, remember to examine the pulse, where you check for the rate, rhythm, and synchrony. You examine the blood pressure. Check the blood pressure using your palpatory and auscultatory methods. You go to the jugular venous pressure and you examine. Then you go to the precordium, check for precordial activity. Is it normal active, quiet, or hyperactive? Then you check for murmurs, palpable murmurs, okay? Thrills. All right, from there, you will now auscultate. Auscultate are those areas, the aortic, pulmonary, tricuspid, mitral areas. Then you also listen to the chest. And that's how you do a cardiovascular examination.